Hello, everyone. Thank you so much for tuning in to find out how you can offer nutritional therapies to your patients with IBD, even if you may not be expert at it. My name is Kaylie Nguyen, and I'm a nurse practitioner at Stanford Children's Hospital in the GI division. I'm a specialist in IBD nutrition and have been teaching my patients the SED and its use in IBD for the past 15 years. It is my pleasure today to be presenting alongside Venus Kalami, who will be introducing herself now.
Thank you, Kaylee. Hi, everyone. It's a pleasure to be here. I'm a registered dietitian and nutritionist trained in nutrition for patients with GI conditions and more specifically specialized in nutrition for patients with IBD and celiac disease.
We have no financial disclosures. In this series of talks on nutritionforibd.org, you've heard Drs. Alvenberg, Cohen, Suskin, and Levine discuss why nutritional therapies are relevant and important. Venus and I will now focus on the who, when, what, and how of implementing nutritional therapy based on our center's experience and the latest research. We hope to inspire and motivate you to start offering nutritional therapies as an option for your patients in your practice. Our objectives are, briefly, to summarize the criteria for patient selection for utilization of nutritional therapies, outline the workflow of our IBD nutrition program at Stanford Children's, describe medical and nutritional surveillance of patients who are on nutritional therapies, and then describe the framework for liberalization of diet and some special considerations. So one important reason to present nutritional therapies as an option for treatment of IBD is that our patient families really want it. Not all patients, to be sure, but certainly some. And the truth of the matter is that if we do not or cannot provide the information or support our patients want, they will look elsewhere for it. In 2016, Dr. Suskin and his group did a survey and had 417 respondents and found that the initial source of knowledge for the specific carbohydrate diet came from a healthcare provider only 17% of the time. 59% of the people initially found out about the SED on the internet and 29% from family and friends. So just this year, our group did a survey led by Dr. Nancy Rivera, who actually will be presenting giving an oral presentation on the results on Monday at NASP again. We had 206 respondents who are either on the SED or cooking for a loved one on the SED, and we posed an open-ended question. Is there anything you wish you knew about the SED before you started it? And here are just a few of the responses. I wish our doctor mentioned it and I didn't have to search for an alternative to medication. I wish more doctors were on board with nutrition-based healing. Another respondent said, I wish I started the diet much earlier in my IBD course. This should be part of the conversation along with access to help, insurance, money, and resources. Another said, I wish my child's doctors had been supportive instead of discouraging and even disparaging me. And I wish I had known about SED and nutritional therapy before biologics. And there are many, many more similar responses. So to summarize, our patients want the option of nutritional therapy. They want us to support them in their journey, and it's our job to learn how to do it and keep our patients safe, even if we do not all become experts on the details of each diet ourselves. So when should you offer? When and how should you offer nutritional therapy to your patients? In our practice at Stanford Children's, we have been working really hard toward introducing nutritional therapy options along with all appropriate therapeutic options for the individual patient based on their disease phenotype, presentation, and severity. If patients are interested and motivated, motivation is so important. Without it, nothing would work. But if they're showing interest and they're motivated, we then proceed in providing them with information, resources, and support. As you would do with meds, it's really important to set expectations, review surveillance, discuss potential side effects or reasons to discontinue, estimated duration of treatment, and of course, formulate a plan B. Some things to keep in mind as far as disease phenotype are that those with small bowel involvement respond most consistent to nutritional therapies. This is our clinical experience, and it is consistent with what has been found in other centers and studies on exclusive enteral nutrition. For those with ulcerative colitis and perianal or fistulizing disease, we've had variable response, and I can discuss that more offline. And for those with exclusive Crohn's colitis, no small bowel involvement, and ulcerative proctitis, we've had the least consistent response. In terms of utilization, we really value and consider diet as a powerful therapy, and we utilize it in all the ways one would use medication in IBD. We use it for induction in medication-naive patients as well as those on meds. We use it as monotherapy in mild to moderate disease. For example, after transition from EEN to steroids, or replacing medications after non-response or loss of response, or if the patient has intolerable side effects to the medications. We also use it in combination therapy when the patient has moderate to severe disease. And we have found that there's a synergistic effect with biologics and immunomodulators in that diet plus those meds tend to enhance response when neither treatment alone is adequate. And as far as age is concerned, we have no limits. Our youngest patient was 2 when he started, and I think if we had anyone younger, we would happily try to modify the diets to help those much younger. And our patients range from those on exclusive G-tube feeds to competitive athletes. So there really isn't any limits in that sense. There are certain patient safety concerns, which I'll review here. Regarding strictures, many of these diets contain large amounts of fruits and vegetables. So for the patients with strictures, you would want to consider staging or starting with the introductory version of the diet, which is usually lower residue and easier to digest. Or if it's a really fixed stricture and not an inflammatory stricture, the patient may not be able to progress onto higher fiber foods and may need a resection even before using diet. In terms of perianal and fistulizing disease, you would want to consider, of course, concurrent biologics, though we have had a few patients remain pretty stable for years on diet alone. For patients who present with growth failure, consider EEN as induction before transitioning to a food-based diet, or start with the Crohn's disease exclusion diet, which includes a 6-week period where there's at least 50% formula. And if your patient is too ill or in too much pain to eat, or at least eat enough to maintain and gain weight, then it's important to start with EN or a short course of steroids just so they feel better before we get them to eat. It is also important to consider psychosocial barriers so that you set your patients up for success. If a patient refuses or has absolutely no motivation to make the necessary dietary changes, then the point is moot, and you should just focus on a general healthy diet instead, which we will go into more later. And regarding time and resources, unfortunately, insurance does not cover the cost of food, and healthy foods can be a cost burden at times. So financial sustainability and resources should be discussed before starting the diet. And regarding time, it's a huge learning curve and will require a lot of time in the kitchen, at least initially. So if you have a family with 4 kids under the age of 5 and 2 working parents, it might not be the best thing to start with. The next is extremely picky eaters. These are pretty obvious limitations because one of the criteria in using diet therapy is to eat enough to maintain weight and meet nutritional needs. So for the extremely picky and rigid eaters, if they feel really motivated, we simply advise small changes over time toward the goal of getting enough variety and textures under their belt to be able to transition to a therapeutic diet without plummeting too much in weight. We advise against therapeutic diets for kids with multiple food allergies, which may eliminate large food groups all at once, like dairy and nuts. And then, except in rare cases or short periods, we do advise against combining restrictive diets, such as the SED plus veganism or SED plus a low FODMAP diet. Go ahead, Manus.
Thanks, Kaylie. Now for the next portion of our presentation, we're going to transition to talking about our workflow here at Stanford Children's for our IBD nutrition clinic. As you'll see, there are a number of steps to our workflow that I'll briefly outline here and then discuss in further detail in the next slides. We are incredibly lucky here at Stanford Children's to have an IBD nutrition clinic that both Kaylie and I lead with the support of our physician colleagues. Our clinic typically takes place once a week, and this slide shows a bird's eye view of all the steps that it takes to get a patient in and set up on a therapeutic diet. And it's certainly an example of what you could do as well at your center. As Kaylie mentioned, interest in diet is by and far driven by the patient, which triggers then the referral, leading to the consult and the eventual start of the diet if diet's a good fit. After that, we will follow up with appropriate monitoring and touch base with our patients as needed. And then with time and patience will come the topic of diet liberalization. So without further ado, we're going to dive a bit deeper into each of these topics during our talk. Starting off with patient interest and the referral. So the patient, as mentioned earlier, shares their interest with their primary GI doctor. However, more and more we are aiming to educate our IBD group and other GI doctors to offer the option of diet as a treatment for patients to consider upfront. But however, once the patient does express their interest, the primary GI then reaches out to Kaylie and I about the prospective patient and then puts in the referral for our IBD nutrition clinic. In the meantime, the primary GI sends a message to the patient with links to reliable resources for nutritional therapies for IBD. So while they're waiting, they can research and familiarize themselves with diet options before coming in. The patient is then scheduled on both of our templates, and this is a particularly important point, more so for the dietitian. In the world of dietetics and nutrition, it's common practice for a dietitian to cover multiple services, multiple clinics, inpatient and outpatient. So it is monumental that a dietitian also has a template and can reserve that chunk of time to avoid double or triple bookings. Setting up the template and figuring out the billing component of an IBD nutrition clinic will be different for every institution, but it does require a little bit of administrative legwork. So that's something to keep in mind if you're interested in implementing something like this as well. And then lastly, to make the most out of our visits, our amazing scheduler will reach out to our family and request a diet history that goes over the patient's usual diet, supplement use, food preferences, food environment, and much more, so that when it comes to the nutrition part of the visit, we have a substantial amount of history to work off of. This is a huge help when it comes to saving time, as many know that a good nutritional history can take at least 20 minutes of time, if not more. Then comes the consult and the eventual diet initiation portions of our workflow. As you can see in this diagram on the right, we first want to understand the patient's motivations and goals for the visit and for nutritional therapy. This is partly to help guide our visit, but also to help set expectations realistically. The medical provider, in our case Kaylie, will discuss the many uses of diet and how in some patients there can be complete, partial, and non-response, and therefore the different medical routes that a patient may need to pursue in those situations. If after speaking with Kaylie, the patient is still interested in a nutritional therapy, then the RD or myself will do a full nutritional evaluation, review the dietary and anthropometric history to make sure that the diet is safe to do the diet from a nutritional perspective. We'll also look into psychosocial factors and potential barriers, as Kaylie previously mentioned, and try to address them, such as lack of time or limited finances, so we can better support the patient and family. And then lastly, through a review of the patient's medical and nutritional history, and from hearing the patient's food preferences, we identify a best fit diet through shared decision making, and then spend the rest of the visit providing education on the logistics of that diet. And then per the patient's needs, we then set up a follow-up schedule that's suited to exactly what they need. So the big question then is, what do you do if you don't have expertise in nutritional therapies, or if you don't have an IBD nutrition clinic? We are here to tell you that you just need to be the IBD expert as a medical provider, but not necessarily the expert in the diet itself. The most important thing to remember about this patient population that's interested in nutrition therapy is that they're extremely motivated and resourceful and will find their way forward with nutritional therapies in one way or another. We also want to emphasize and reassure that there are many reliable resources online that you yourself can review as a provider and or refer your patients to gather further information. These include ntforbd.org, which outlines major nutritional therapies for IBD. For more specifically on the specific carbohydrate diet, there are a number of resources such as Nimble, Breaking the Vicious Cycle, and pecanbread.com. For the Crohn's disease exclusion diet, patients and providers can go to mymodulilife.com. Lastly, but certainly not least, patients can also check out reputable Facebook groups and blogs, and even more recently, seek out online nutrition services, which are becoming increasingly common and help increase the patient's accessibility to nutritional care. Now, after getting the patient started on a diet, the next step is nutritional monitoring. And within nutritional monitoring, there are a number of domains that are important to assess. First and foremost, we want to review the patient's diet and make sure the patient is adhering to the diet. Meanwhile, that they're consuming a wide variety of foods within the confines of their diet. So we're really trying to make sure that our patients aren't just eating a bunch of dried fruit bars all day or just eating rice and broth. And this is to ensure that they're receiving adequate macro and micronutrient intake. To do this, especially if you don't have a dedicated IBD dietitian, be reassured, as what you really need is a dietitian who is well-versed and adept at assessing macro and micronutrient intake. If you as a provider don't have a dietitian, then it is going to be up to the patient to really, one, adhere to the diet, and two, aim for as diverse of a diet as possible. However, as a medical provider, it will still be really important to perform nutritional lab monitoring by checking levels of common micronutrients that can be low, particularly in patients with IBD, and particularly those on restricted diets, such as therapeutic diets. A couple of micronutrients that come into play here are vitamin D, thiamine, folate, zinc, iron, amongst many others. If levels are low, or patients are struggling to get enough of these nutrients from their foods, then it would be up to the medical provider to prescribe targeted nutritional supplements for their needs. We also look at energy levels and anthropometrics to make sure they're consuming enough calories in general. And if they're low in energy, then that might tip us over to one, they're not getting enough calories, or not enough of other macronutrients or micronutrients. If they're flaring or having any kind of digestive responses to their new diet, then we might modify the diet to make it a bit more tolerable for the individual patient. This might look like increasing sources of soluble fiber and perhaps decreasing intake of more insoluble types of fiber. Lastly, but most importantly, follow-up is going to be driven by the patient's need. Are they more medically complex? Do they need more support and guidance? Then support them. With time, be reassured that follow-ups do decrease in frequency as patients and families become more confident and adept at the diet.
So I'll review medical surveillance. Depending on the patient's nutritional status, clinical symptoms, and how close their baseline diet resembles the therapeutic diet, we recommend initial follow-up within 2 to 8 weeks. Like Venus mentioned, we monitor anthropometrics really closely. If the weight drops more than 5% within less than 2 months, we work on caloric fortification within the diet and follow up with that patient much more closely. If the weight drops more than 7%, we discuss a slower transition onto the diet to allow more food choice and caloric intake, or we consider a different therapy. And it may be a different nutritional therapy or a different diet, not necessarily medications. As we discussed before, assessing psychological well-being and providing support is really important. We recheck calprotectin and or labs if they presented with abnormal labs 6 to 8 weeks after dietary initiation and after they reach about 95 to 100% compliance on their best fit diet. And this is just one of the data points. The calprotectin is just one of the data points we collect to help us determine response versus non-response, which then helps us determine the need to add or escalate therapy. So as far as determining response, we discuss all of these points outright with the patient the first chance we get so that we set expectations. First, we allow time for transition onto the therapeutic diet, which may take 2 days to several weeks. Time 0 is when the patient, again, is at least 95% compliant with the best fit diet. We explain that not every patient responds, reasons of which are multifactorial, and sometimes we go into it a bit if they're interested. If a patient is to respond, though, they generally begin showing clinical and or laboratory improvement within 2 to 4 weeks. But clinical remission and normalization, or at least near normalization of calprotectin and disease activity scores can occur as early as 3 months, but as long as the trend is good, the patient's adjusting well, feeling well, gaining weight, we do give them up to 6 to 12 months to completely achieve remission. We explain to them that clinical response is the same as with any other treatment or medications, which include resolution of clinical symptoms, of course, improvement and eventual normalization of labs, weight gain or maintenance, and eventual linear growth. And then, of course, mucosal healing is entirely possible. So let's say they respond completely. If they do, then they remain on the diet or the best fit diet as strictly for as long as possible. And we really emphasize at least 6 months, but 12 months is so much more ideal, and even longer, and that is even better, because the longer they stay, the more likely they'll be successful later on in terms of liberalization, which Venus will cover later. We do check a calprotectin every 2 to 3 months while they're on their therapeutic diet, so we can track their response and predict any early flares. And we do adjust medications or even withdraw medications if appropriate and if that's part of their goal. If they have partial response, then they can certainly continue the therapeutic diet, but we might consider adjunctive therapy and reassess goals. If they have no response or they have negative side effects or they can't maintain weight, then we talk about transition to a general healthy diet or escalation of therapy. There are some special considerations for our patients who do dietary therapy. For some patients, their main motivation to do diet is to avoid blood draws. You'd be surprised how common that is. So if they respond really well and they feel really great, they tend to avoid returning to clinic at all costs. So just be sure to emphasize to your patients that the IBD is not necessarily curable. And if they respond to diet, that's great, but they should continue to return to clinic for various reasons in terms of receiving IBD healthcare maintenance, getting information about new research and recommendations, vaccines, assessing for extraintestinal symptoms that they may not recognize as part of IBD, assessing for complications, reminding them for the need of subspecialty care such as optometry, and of course, disease surveillance and rescoping and re-imaging. And then to monitor nutrition and growth and to support them with that.
As with any big dietary change, success does not happen overnight. And for that reason, we say give diet some grace. It truly takes time, experience, and experimentation to become proficient in a nutrition therapy. That being said, slip ups, accidentally eating something you're not supposed to, and so on are all a part of the learning process. I have many patients who'll eat something that's not allowed on their diet on accident and then ask me, often distressed, what they should do to correct their mistakes. Half jokingly, I tell them that there's really only one treatment to dietary slip-ups, and that is acceptance, learning, and moving forward. That is it. Now, when starting a nutritional therapy, it is possible for some patients to feel off as they adjust to the diet. That might mean they feel fatigued, have brain fog, or even feel sad as they're kind of mourning the loss of foods they'll no longer be eating while waiting to come across foods that they love. Additionally, depending on the diet chosen, and particularly in the case of the specific carbohydrate diet, some patients may report bloating, increased stooling, or abdominal discomfort, which is often related to the sudden increase in fiber intake compared to the patient's previous standard diet. In these scenarios, we work with patients to help ease them into a diet that they best tolerate as an individual patient while we're waiting for their microbiome to acclimate to this increase in fiber. In the case that the patient is low in energy, lethargic, or tired, it's crucial to assess that your patient is consuming adequate calories, first and foremost, and especially that they're consuming enough carbohydrates, especially when it comes to patients who are physically active or who are competitive athletes. And of course, assessing and addressing their iron status and overall dietary iron intake will be important as well. As a result of getting used to the diet, slight weight loss may occur. However, we want this to be temporary and for our patients to resume age-appropriate growth as quickly as possible. If patients can't maintain appropriate growth on the diet, as Kaylie mentioned earlier, then nutritional therapy may not be a good fit. We'll of course support our patients as much as we can, but we want to give them an out in the case that the diet isn't working for them. In those cases, then the goal transitions to guiding our patients to a healthy diet for patients with IBD. And again, I want to emphasize that taking on a therapeutic diet is a huge change and a daily commitment. Mastery doesn't happen overnight, and it is indeed a marathon. After a patient gets established on their best fit diet and is showing positive response to the diet, then the conversation of liberalization will naturally present itself. I'd say that this is also patient initiated as well. Liberalization is in some cases a long and winding road, and I'll touch more on what I mean by that later. This process will depend largely on the diet that's chosen. If the patient is on the Crohn's disease exclusion diet, the CDED, for example, then the liberalization process is naturally built into the plan. If symptoms arise during liberalization, then patients can go back to a previous phase of the CDED and progress more slowly if needed. If they are on EEN, exclusive enteral nutrition, the next steps will depend largely on what is next in their therapeutic course, whether EEN is a bridge to medications or if they're weaning to partial enteral nutrition or to another nutritional therapy. If a patient is on the specific carbohydrate diet, we have seen in our center that patients maintain remission best when they're on a strict specific carbohydrate diet for at least 6 months, but more preferably 12 months. And this will depend also on the patient. Here is where the long and winding road comes into play. Reintroduction of foods on the SCD is a step-by-step and methodical and individualized process. We aim to introduce foods that have historically been well tolerated by our patients in the past, such as sweet potato and oats, for a more modified version of the SCD. After each food reintroduction, we follow up with a calprotectin about 6 or so weeks later to monitor for any inflammatory responses and to help further guide our next steps in the liberalization process. If they're tolerating new foods well, then we will continue to add foods in one by one in this methodical process. If they're not tolerating the new foods well, then we may encourage patients to go back to a strict SCD, wait a few weeks, and experiment with a different food. Just a note here that for some patients, liberalization can be a bit of a slippery slope, as they will naturally be eager to go back to eating some of their favorite foods that they were eating before, and perhaps in a way that's a little bit faster than this current model of liberalization allows. If you have a suspicion that your patient is at risk of going down the route of non-adherence, then support them further, acknowledge all their hard work so far, and try to get creative to recreate some of their favorite foods and help mitigate that feeling of deprivation.
So as Venus mentioned, for patients who do not respond to or cannot sustain a therapeutic diet long-term for whatever reason, we encourage a diet that is generally healthy and much, much less restrictive. This table here is adapted from the various amazing charts found on this very website, ntforibd.org. Thank you, Vonda, for putting that together. I know there's a lot of information here, but I just want to point out that except for formula and a few exceptions, these therapeutic diets, by and large, exclude wheat, exclude preservatives, synthetic emulsifiers, corn syrups, and really high sugar foods. The types of grains and other starches that are allowed outside of wheat are variable depending on the diet, and many of them do offer or allow dairy in the lactose-free form. So when we tell our patients it's best that you go on a healthy diet for IBD, we have typically advised over the years a low gluten, low lactose, low sugar, whole food-based diet. And the great news is that very recently, in May of 2020, Dr. Ari Levine and the International Organization for the Study of Inflammatory Bowel Disease published the following guidelines based on the existing data on IBD and diet. As you can see, we have not been too far off in our recommendations that was based on common sense and our center's experience with nutritional therapies. Basically, you stick to whole foods, low in saturated and trans fat, avoid preservatives or anything that you can't pronounce that well. And if you have Crohn's disease, you want to eat more fruits and vegetables. If you have ulcerative colitis, you try to consume more foods with omega-2 fatty acids in the form of fish and food, and you eat less red meat. And that's what we recommend for our patients.
Thank you, Kaylie. As we begin to wrap up our presentation, I wanted to take a moment to acknowledge all of the wonderful projects we have going on behind the scenes. Here we have a snapshot of a part of our IBD nutrition team. We gathered in a professional kitchen to record a number of tutorials for how to create delectable SCD treats, all thanks to a grant that was obtained by our amazing pediatric resident, Dr. Nancy Rivera, who's also presenting at NASPGHAN, as Kaylie mentioned. We gathered to record these in preparation for an upcoming study entitled Scrumptious, which is the study title acronym. And this is through the mentorship and guidance of Dr. An-Ming Ye. There's more to follow on the next slide too. Here we have some snapshots of a part of our IBD nutrition team and some photos of delicious and crisp carrot and beet chips that we made, as well as some SCD legal crepes.
And I just want to emphasize that just because somebody's on a limited diet or a restrictive diet does not mean there are no available, amazing, delicious food. You just have to be creative and explore, and you'll get bunches of variety and deliciousness.
To conclude our presentation, we wanted to also acknowledge how incredibly lucky we are to have an IBD nutrition program at Stanford Children's, and we hope to inspire you to pursue doing the same at your IBD center, or at the least entertain the option of supporting patients interested in diet for IBD. We receive local, regional, and national referrals for nutritional therapy for patients, and we have a number of exciting projects going on behind the scenes. If you're interested, you can read further on the slide to learn more. And of course, none of this would be possible without the support of our entire IBD team, and especially our amazing physician partners, Dr. An-Ming Ye, as well as Dr. Alka Goyal, who has more recently joined us. Thank you everyone so much for joining us here today for this talk. We hope we've inspired you to implement an IBD nutrition clinic, or at least further support your patients interested in nutrition for IBD. If you have any questions or would like to talk further, both Kaylie and I would be thrilled to get in touch. Our contact information is on the slide for anyone who's interested.
Good luck to you. Have a great day.
Thank you, everyone.